is an organization that champions the lives of Black people in the areas of health, economics, justice, and education. Thank you for joining us for tonight's community conversation, Fighting COVID-19 Together with Facts. Please remember this conversation is being recorded for rebroadcast, so please keep yourselves on mute. If you have questions, be sure to put them in the chat and we will try our best to get to them. Please welcome tonight's moderator, Teresa Burvell, who will introduce our panelists.
All right, thank you, Eric. Hello, everyone. My name is Teresa Burvell, and I work at Providence Alaska Medical Center in Anchorage in the role of Chief Mission Officer. I'm honored and humbled to be the moderator for today's session. Next, I would like to introduce the panelists. We are so grateful to have a panel of presenters providing us with expert information and variety of perspectives and insights on the topic fighting COVID-19 together with facts. As part of preparing for today's session, we have a list of questions that I'll pose to the panelists. Our goal today is to deepen not just our knowledge, but equally important, our sensitivity of issues and needs pertinent in the environment of fighting COVID-19, higher rates of infection and disparities experienced by Black, Indigenous people of color. First, we have tonight Dr. Jocasta G. Olb. Dr. Olb is an accomplished leader and diversity, equity, and inclusion champion with a proven track record of success and over 10 years of healthcare experience. She's formally trained as a clinical pharmacist, antimicrobial subject matter expert, and managed care professional. Dr. Olb is the manager of clinical innovation for CareSource and serves as the COVID clinical health and equitable communities coordinator for the State of Alaska Department of Health and Social Services, Division of Public Health. Second, we are pleased to have with us Reverend Mr. Leon D. May, who accepted the divine calling into the Christian preaching ministry on January 28, 1980. In Alaska, Pastor May has served on the pastorate Greater Friendship Baptist Church for 12 years and is the current pastorate. He also served in the River in the Desert Community Church for 12 years as president, as well as the Interdenominational Ministerial Alliance of Anchorage, Alaska, and vicinity. Reverend May is married to the former Miss Cynthia A. Cole for 36 years, and they are the proud parents of 6 children and 8 grandchildren. Welcome, Reverend May. Next is Dr. Richard G. Berry, MD, FACP, CSA, who is board certified in the specialty of internal medicine. He is a fellow of the prestigious American College of Physicians. He holds the position of Associate Professor of Medicine at the University of North Carolina in Chapel Hill. With this position, he trains future medical doctors in the art and science of medicine. Dr. Berry is presently affiliated with the Health Ministry Department of the South Atlantic Conference of SDA under Pastor D.M. Jones as a regional representative. Dr. Berry is the author of several health-related articles and magazines. He's a church head elder, pathfinder, master guide, and the husband of one wife, Charlene. He has 2 beautiful adult daughters. Finally, Dr. Berry considers himself a humble servant of God and gives glory to God and to God alone for all that he has done in his life. Finally, Naboni Gates is a health educator and coordinator with South Central Alaska Area Health Education Center and Alaska Primary Care Association, focusing on workforce development of the community health workers and integrated health career pathways for ESL population. In addition, she's a program coordinator for the Peer Leader Navigator program at Alaska Literacy Program, which focuses on health outreach, connection, and navigating healthcare and social services. She received a Bachelor of Science in Health Sciences from the University of Alaska in 2019 and is a certified health education specialist. She's very passionate and driven to work on immigration and refugee integration and addressing issues of health equity through community-based efforts. Over this year, she's been working very closely with communities to be well informed on COVID-19 safety and helping address needs exacerbated by the pandemic. A big welcome to our panelists and thank you all for being here. Now, I would like to welcome our virtual audience, both locally and nationally. We are so glad that you are joining us for this panel discussion. We will take audience questions at the end of the question and answer conversation. We will now begin with Dr. Ope. Welcome, Dr. Ope. We look forward to your presentation tonight. First, I wanted to say that when we return from the presentation given by Dr. Ope, we will turn our attention to the panelists who will share any thoughts that they have on the presentation data. Thank you. Dr. Ope, you may begin when you're ready.
All right, just give me one moment. Oh, you might have to do it for me. I cannot share my screen right now. I know I sent you the slides, so if you want to show those, that's fine as well.
Dr. Ope, I can give you permission to share your screen.
Okay, either one will work.
Okay, you should now be able to share your screen.
Okay. Perfect. There we go. Hi, everyone. I will be brief with this, but I was just asked just to share a little bit of overview, just what we're seeing with the science, the safety, and things to expect. So I'm going to talk a little bit about vaccines, but also jump into just the data of what we're seeing, some demographics information that we're seeing nationally, and then also in Alaska. So again, I am Dr. Jocasta G. Ulp, and the majority of this data is from either the CDC or from Alaska Department of Health and Social Services, and you can go and access this data on the DHSS website and see the most up-to-date figures too. So this is just really in coordination with just vaccine efforts. And I'm sure that this might not be anything new for all of you, but it's just going through the efficacy and the safety of the vaccines and how our overall goal is that individual protection and also the community protection. And so we've been, we have been disseminating the vaccination since the winter here in Alaska, and we started off with a really strong push. There was at one point where Alaska was the top in the nation for how our vaccination efforts were. But one of the things we noticed at the beginning of that was that there was a decrease in the amount of vaccination rates that we had among our African American population specifically. So I did do a talk back, I think that was at March maybe, in talking through that, and we did see some numbers uptick, but we're starting to focus back on this, making sure that individuals are getting vaccinated. I'm actually gonna jump ahead because I don't want to take up too much time because I really do want to get to the panel. But really with this, so, the vaccines in itself and the data that we show, it's just that extra protection. It goes along with all of the other elements that I'm sure that you're all continuing to do: washing your hands, social distancing when you can, wearing your mask out, and then that completing the vaccine series. So it just makes all of those different layers out there. And as of now, the vaccines are available going down all the way to the age of 12 for Pfizer, Johnson & Johnson, so that one and done dose at 18, and then Moderna is the 2-dose series and that starts with 18 and above there. We also have, and I apologize, one of my dogs are barking in the background. We have, there's been the third dose has been authorized for individuals who are immunocompromised. And so then that's a little bit different too. So there's a difference between what you're hearing about the boosters and what you're hearing about the third dose. So the third dose, you do that in conjunction. So you have 1, 2, 3 right in line. And then that's just having 3 doses as the actual series versus that booster that would come much, much later. But you can see the breakdown there. And then with the Pfizer one in particular, over the last few weeks, that one has actually gotten full FDA approval. Beforehand, all of the vaccines, they had the emergency use authorization, but that one actually has the full FDA approval that's been out in the market. And again, this is just more information about the difference between that additional dose for those individuals who are considered immunocompromised. And you hear that a lot, but that's just those people who have had either an organ or stem cell transplants, thinking those who might have had kidney transplant, bone marrow transplant, those with untreated HIV infections, if you're actively being treated for cancer, or if you're taking any medication that might weaken your immune system. And the verdict is still out on boosters. I know there's been a lot of talk about that, and there was the recommendations from the panel that happened yesterday, but those are, until we get the FDA's approval, it is still not complete yet, but it's looking like that's going to be 65 and older, or those individuals who are at high risk. And at the very end, they mentioned people who are healthcare workers. So more to come on boosters. Let's get past this one and go straight to what we're seeing with the data. So this is the makeup of the entire United States. And so when I pulled this data on the 13th, because they kind of do it in blocks, but what we're seeing overall from the demographics breakdown by race and ethnicity, we're seeing that, and they're basing these numbers compared to the total population. And so it's not for each, it's not based on each other, it's based on how much of that makeup of the race for their population. So that way you can see these numbers. So if we had 100% of individuals who identify as white and 100% of individuals who identify as Black, you would see those both. So it's not proportional to that demographic breakdown, but we're seeing roughly across the United States that individuals who are either Alaska Native or American Indian, that they're have 55% have 1 dose and 47% are fully vaccinated. The Asian population, we're seeing roughly 43% have at least 1 dose and 42% are fully vaccinated. For the Black community, we are, unfortunately, we're lower on these charts. We're at 34% that have at least 1 dose and 30% that are fully vaccinated. The Hispanic and Latino population is 41%. And 41% and 36 are fully vaccinated. Those individuals who are Native Hawaiian or Pacific Islanders, they are at about 45%, and then 40 are fully vaccinated. And then those who identify as white are 40% with 37.8% fully vaccinated. One thing to note when you're looking at these charts too, that there was a considerable uptick for the Hispanic population that happened around June. There was a really concerted effort with that population, and they had the spike in jumps for several different reasons. So just something to note there, that that these trends, they're with outreach and with talks, that can make a difference in really encouraging people to get vaccinated. So what are we actually seeing here in Alaska? With Alaska's same breakdown, we don't have that. We only have the count for getting at least 1 dose. We don't have it with the 2 doses. So I just wanted to level set that piece of it, but I think I jumped there. Sorry about that. So we only have the 1 dose, but what we're seeing here in Alaska is pretty much on trend of what we're seeing with the nation, where you've got the American Indian and Alaska Native populations higher. We're seeing it even higher here because of the efforts that have happened within the various Alaska Native hospital systems to really get their individuals and their patients vaccinated. So that's at roughly 63%. Kind of counter to that, if you look at the Black population here in Alaska, only 31% of us are actually vaccinated. And that's really, and remember, that's getting that one dose. So the assumption is that for those who are fully vaccinated, that the numbers would be even lower than that, because there are some people who have not finished the course. So we have a lot to be done in this space when looking at the data. We're as compared to some of our peers, we're behind the curve here, and really wanting to talk through that today and help to alleviate any fears, hesitations, and getting those numbers up. And then as just to show too, what are we seeing from cases of COVID? This one's not as great of an apples to apples comparison, because what I can't figure in with just the basic data that I have is is whether or not you have an individual that's only gotten COVID once, but we do know that there are some individuals who've gotten COVID multiple times. So it's not straight, apples to apples there. But what we're seeing, just kind of rough data points, is that for the Black population, the COVID cases, there's about 8% of the Black population has gotten COVID. You can kind of see that across the board of how we're breaking out and breaking down from the case count too. So it does seem, when you kind of hear these numbers, it seems small, but when it comes to the epidemiology and the scientists who study this, though we live in the world of pandemics being at really small margins. So if you're hearing these lower case rates, you think it might not happen to you, but it really does. When you scale it, it can affect many, many people. And I'm sure you all have heard stories or know people who have gotten severe COVID, who've gotten COVID, who've died from COVID. And, even one, having one person on there is not what we want to see. So I just wanted to provide that information and the lay of the land. Like I said, I won't belabor too much because I really want to get into this panel. So I'm going to stop sharing my screen, and I'll turn it back to you, Teresa, to kick us off.
Thank you so much, Dr. O. That was such helpful information. And I really want to, before we even go into the question and answer session, to turn my attention to you all, the panelists, to take a few minutes to share any thoughts you have on the data that was presented by Dr. O. So I'll call on you, Pastor May, if you can go first. Do you have any comments, any reactions to the data?
Well, no, the data is pretty standard data, as Dr. Oak alluded to. The thing is that the one thing I did note relative to the Pfizer is the age on it is 16, but as of, I guess, today, a couple of days ago, whatever, roughly 74% of people aged 12 and older in the U.S. have received at least a dose of the vaccine, with about 64% on the national scale fully vaccinated, and that's CDC data. And I noticed most of it was pertaining to Alaska, which is cool. But I did want to mention that there are 12-year-olds in Alaska that have been vaccinated.
Thank you so much. Dr. Berry, any comments?
Yes, as of 3 days ago in Alaska, 98% of the individuals who were hospitalized were unvaccinated. And most of the type of COVID virus was the Delta virus. I want you to understand what that means. Behind me is a picture of a COVID projections, this picture. Those projections are called S proteins, or spike. This is what attaches to the cells of your lungs or your stomach or your heart and injects the material inside into your cells to produce more of the virus. That's called the S protein. The Pfizer and Moderna produces a RNA that produces this S protein, an antibody, so that when the antibody is produced and the body sees this virus and that spike protein, it destroys it. The problem is we waited too long. Because we waited too long to start this process, this S protein has changed. It has become a variant. The variant means that it's changed to the point where sometimes the virus gets spread to different people in the hospital, and especially those who are not vaccinated, it can kill them. 98%, as I said, in Alaska. Now, Alaska has a population of 773,548. In Alaska, there have been 99,590 cases of COVID and 450 deaths as of last week. So we can see that there's a problem here. 17% of those between the age of 12 and 17 have had their first dose of the virus vaccine. 65% of those between 18 and 64 has had their first dose. And 95% of those between the age of 65 and above have had their dose. So we need to work on those between the ages of 12 and 64. If you're in that category, you need to get your vaccine, because we are in a battle here. 8 days ago, we celebrated 9/11, where 2,996 people died. We went to war because of that. As of yesterday, there were 674,000 deaths in the United States alone. 674,000. We are at war. We need to put on our armor. We need to get vaccinated, especially in Alaska, and take care of this.
Thank you so much, Dr. Berry, for the comparison and for stressing the need to get vaccinated. Especially for the community. I want to go to Nyaboni. Do you have any comments on the data and how we can really get these numbers increased?
I don't really have many additions other than I think it's important to look at the data and to share it with people in a way that they understand. And to Dr. Berry's point, making it just, we're at a critical space, and so really working with communities to understand why it is so important that we are pushing the message of people getting vaccinated to continue to follow the safety precautions and whatnot. So thank you for sharing that.
Thank you so much for all of your comments. And definitely, the way we present the data is very important. The general population understanding the data, do they understand the breakdown and the backgrounds, when we talk about all of this data? And so I want to go back to you, Dr. Ope. What are the current state trends in COVID infection and vaccination rates by race? I mean, you probably have mentioned this, but I just want you to compare and stress a few things that will kind of, in very simple ways or terms that people can just grasp. How does Alaska compare to the national trends?
Yeah, we are right on track with the national trends, which is not a good thing. I will say that. So where the only place where we differ is with the Alaska Native and American Indian population. Our state has had a much larger vaccination rate because of our concentration of the Alaska Native population. But when we're looking at the Black population, specifically and thinking through the audience today, we're right there at that trend, if not a little bit lower nationally. For those who've had one dose of a vaccine, that was around 34% who've had one dose, and in Alaska we're at 31% of our population, of the Black population. So and we're behind all other races right now of getting vaccinated. And so it's not a place where we want to be with that trend. We want to get vaccinated. We want to start to increase and really jump up our numbers, because where we're hurt, we do hurt more is in the idea of those severities and those individuals who we're seeing dying from COVID and having those severe cases too, which has not changed since the beginning, and we've talked about this a lot in our community. And so yeah, and so we don't want those numbers to be with the trend. We want to be much ahead of that here in Alaska.
I'm so happy to hear the high compliance rates with the Alaska Natives. But the disparity is so big, and obviously they must be doing something very well. So what do you think is driving the disparities in outcomes? And this goes to you, Dr. O. Just a follow-up question.
Yeah, well, one thing in particular that there's two things here, with one having a dedicated hospital system for that community is definitely a plus. It allows to have that trusted voice, and having someone who looks like you, who's able to speak to you, who you entrusted in your care. So there's one thing, and that is something that we don't necessarily have here for the Black community nearly as much. And then there's also the more recent history of pretty severe illness running through the Alaska Native villages. And those stories are so fresh on some of those families' minds, where you might have an elder in those villages who were the only survivor of some of those viruses that came through earlier in the 1900s. And so it is top of mind to protect themselves. And so their memory of receiving or not receiving healthcare is a little bit different than our story and our history that drives our hesitancy. So kind of, on the same fold, ours drives our hesitancy a little bit more, and theirs drove their action a little bit more. And again, it's just a difference of our lived experiences that we're going to have to push through.
Thank you so much. As you were talking, I was just thinking about racial concordance. It's like, what are we going to do so that we can get more Black Americans or Hispanics, into healthcare as physicians and as providers? Because we know that they feel more comfortable when you have someone who looks like you talking to you and encouraging you to get vaccinated. It also encourages you just on a whole to get access to care, So I know there is a big gap, but there is an opportunity here for us to think about how can we get more diversity in medicine as well. And this brings me to Nyaboni. What barriers are you faced with?
Could I add to that?
Yes, please, go ahead.
Most of the studies that I've reviewed for this program found that the reason why Blacks and indigenous people are slow to get the vaccine is because of distrust of the medical community. There's a distrust of the medical community, and it's not based on anything. It's based primarily on the Tuskegee study. You remember the Tuskegee study where African Americans treatment because of syphilis, and they wanted to see, the Army wanted to see what syphilis does. So it's a distrust of the community. We need to go with the science. Yes, there may be a distrust, but we need to cover that because we don't want to die. So yes, I'm glad at what that young lady said there about there is a dedicated area where people who are known will be able to do this process. No more.
So this goes to Nyaboni. So what barriers are you experiencing or facing in the community? What are they telling you? Can you tell us some examples that contribute to this mistrust of people who are minorities?
Yeah, thank you for that question. And I think Dr. Berry and Dr. Olps have already touched on it as far as, some of the history. when it comes to the medical system and what has happened in the past. But also what we've seen as we're working with individuals is just one, not having enough information to make an informed decision, but also where that information is based off of, which is misinformation. And there's just so much information out there that confuses people too. And it's hard to distinguish, what is true and what is not true. And, whatever information that people are reading or people are hearing about, that could drive their fears or their hesitancy. And whether it's, perceived from something that's fact or fiction, it's still fear, and it still prevents people. And then also, I think, just kind of understanding, because this is a new, but we're not new to how viruses work, but COVID-19 is like, it's new to us. And so, the barrier is how COVID still plays out and how it still impacts people. And then the vaccination itself, people are still fearful and trusting the vaccine, whether it's its timeline and how quickly it was put out to the public, or just some of the misinformation around, and many of you have probably heard these of like microchips and being tracked or whatever it might be. And then, when I think other barriers where people might want to get the vaccine or get vaccinated, it does take time, time to go to the location, and, whether you're taking time from your work, do you have time off? Do you have childcare? Do you have transportation to get there? And then, what we've also seen is people have reactions after they get vaccinated. So as people are seeing that, those are things that they consider to move forward. Whether, it's like, oh, if I'm going to be down for 1 or 2 days, can I do that? And so I think there's many barriers, individual and structural. So those are just a few. And then, of course, I work with the ESL or immigrant and refugee population. And so language access is a huge barrier as well. And kind of understanding the communication and the materials, and kind of trying to break that in plain language is a huge barrier. And if people are not informed and they still have questions, of course, they're going to be very hesitant to proceed. So.
Wow, thank you. Thank you for sharing facts around transportation, access, misinformation. Those are really genuine, it causes a lot of fear in people. And so I'm going to turn my attention to Pastor May, because you interact a lot with the community. What are you hearing and what are you telling them when they come to you with their questions, their fears, their concerns? If I was going through that, one of the first people I may probably go to share some of these things would be my pastor. I know even when we talk about religious exemptions, people are being asked to get their pastors and, to sign for those religious fears. So what would you be telling them? Are you going to tell them to really get the vaccine instead of signing to release them from getting it? So I'll let you answer.
All right, thank you so much. And I'm grateful to all of the other panelists and the expertise that they present. And but in reference to what has been shared, and then my portion in answering this question, I wanted to go back briefly to the distrust or mistrust factor. There are many folk who are not even aware of the Tuskegee experiment and what have you, and they still have fears and they still distrust and mistrust. And the only thing that can expel the distrust is the creation of trust. And yes, there needs to be those who look like the individual that's trying to be helped, and that would move it along. But the only thing that builds trust is relational. And even if with somebody who looks like me, I, us, or what have you, there's a certain distrust even there as it relates to what are you regurgitating? How do I know that this is on the up and up, and what have you? And so relationships being built between doctor, patient, and what have you is what's missing, I think, more than anything in our community. But as it relates to fears, questions, concerns, and all of that centered around COVID, there are a number of those fears and questions. A lack of knowledge basically is a big deal as it relates to coronavirus. A lack of knowledge concerning ingredients. Folk, how can I be settled on the issue of what's involved, the ingredients in the vaccination, and that's that's off the top. There was all of this stuff about the fetal lines being used in the experimental phase of it, but not being used in the actual vaccine and all of that. And you alluded to a minute ago about folk wanting exemptions and all of that religious. Well, that's not really anything religiously related that would exempt one from this type of vaccine. And that's we try to convey that, because when you think in terms of fetal lines, I was just reading in an article, I think it was earlier, that those same things are used in ibuprofen, Tylenol, Pepto-Bismol, and you have to reject all of that to reject this particular vaccine, if you would. And so it's a lack of knowledge folk have concerning ingredients. I don't know what's in it and all of that. Some folk talk about government control and what have you, concerning personal health decisions and all of that. All of these are fears and or concerns and questions around the vaccine. Some talk about it hasn't been around long enough to know potential long-term side effects. So those are some concerns that folk have. But if we just be honest with ourselves, vaccines have been around for a long time. Even someone of my age and many of you, to even be involved in a school environment from elementary school on, there were requirements of certain vaccines. And there was not a whole lot of fight about it because you had to have it to get in school. Those who served in the military have seen all kinds of vaccines and what have you. And so if we would just think in terms of experientially and look at the overall view of it all, if it's something that's going to help alleviate the situation that we are now in, which is dire, if you will, then it's good and beneficial for the whole. But some of those concerns, and then when Alaska opened up earlier, opened back up, and all of the requirements were lifted as it relates to really masking and social distancing and all of that kind of thing, and restaurants reopened and all of that. There were folk going around that I talked to and had explained to them that they were saying COVID was over, and we had to re-educate folk to the fact that COVID hadn't gone anywhere. We're still dealing with it, and we are now in a dire situation as a result of quote unquote a misguided, I would say, reopening. And those are some concerns and things that I've had discussions with folk about community-wise.
Thank you so much for sharing that broad community hesitancy. That's very helpful. And okay, so I thought I saw a hand up, but we'll get to the audience very soon. I just wanted to look at how, as a community, and even for physicians and for pharmacists, how do we convince people, to not be afraid and to, to take this vaccine and to address their misinformation. I'm going to go with Nyaboni first, because I know that you are based in the community of immigrants, of people arriving in this country, of, you are in close contact with them, you hear what their fears and concerns are. What is the approach? I mean, how do we find the most effective ways to try to convince them to get vaccinated?
Yeah, I think that's a really good question. And as we've been working with people, I think it's very simple. It, comes down to active listening and really taking the time to understand what someone's concerns are and what their obstacles may be to getting vaccinated, to saying, yes, I want to get vaccinated. Because most of the times it's not just mistrust, but it's also people have true barriers to getting vaccinated, whether it's medical, whether it's structural barriers, and then just providing accurate information and trying to answer their questions with credible sources and showing them. It's one thing to hear it from you, but if you can physically show them how they can find and use those tools, not only for this vaccine, but in the future when it comes to health information, I think that will take them a longer way. And it's almost like the idea of getting assigned a reading. So like I love to read, and I love to read for pleasure. But if a teacher, or if it's assigned to me, then I'm less like reluctant to go along with it, or it might take me longer to kind of understand what I am reading. And so I think the same idea with trying to convince someone to get vaccinated, they come to that on their own terms. And then the second thing is, I know there's this urgency to get as many people vaccinated as possible, and probably don't want to hear it, but it's time, and having the conversations and an open door to, maybe someone says no now, but maybe you bring it up again with them, and you kind of ask, where are you at? No does not mean that they're never going to want to get vaccinated. It just means that they still need something that, can let them remove the meter to the other side, where they can say yes. And with the new vaccine, there's a lot of questions and a lot of unknowns, and that's really scary for people, and information overload. So again, it's just, if I'm working with a person and I know kind of who they are and how they process information, I might not give them like a 2-page information on COVID. I might just maybe give him one that's like a 1-page fact sheet, or maybe direct them to sources that put things more in plain language, or a lot of our people speak a second language. So it might be finding resources that they understand and can connect with the most. And then just helping people find their reason why. Everyone has a different reason for wanting to get vaccinated, whether it's because of a family member or their own health condition, or whatever it may be. So helping people find their why, and just kind of, again, taking time, being patient.
Thank you so much. Having worked in healthcare for over 15 years, I know we are very good at information overload, and perhaps sometimes for these communities, it's just making things very simple so they can understand. So thank you for sharing that. Talking about healthcare and the role of physicians and how you can convince families and friends about the vaccine, I'm going to turn to you, Dr. Berry. What steps can physicians and providers take to address the mistrust of vaccines within communities of color? And what knowledge at all or tactics have you used to help educate your own patients or family members who are skeptical about receiving the vaccine? Because this is real. It's happening.
Yeah, yes. Thank you, Teresa. I have had 2 approaches The first one is I have to be patient with my patients. But my patience is running thin because I know what's going to happen in November. No, I don't know how cold it is in Alaska, but it gets real cold here in North Carolina. And when you get people who are together in a cold situation, the virus spreads. So I am acutely aware that around October, November, December, there's going to be a spike if you don't get it under control now. So yes, I am patient with my patients, but my patience is running thin because I need to talk to them and get them immunized before November comes. So I tell them two things. The first thing I tell them is this: if you don't get vaccinated, the risk of you being hospitalized and dying are very high. In Alaska, 98% of the people who were hospitalized were unvaccinated. 98%. That means only 2% will get sick, but they don't end up in a hospital or in an ICU. So I tell them, if you're unvaccinated, the virus inside of you mutates, becomes a variant. And when you breathe that out, I breathe that in. And if my immunization is not controlled, you could kill me. So I wear a mask to protect myself and my patients. So I tell them, go and get the vaccine, not to just save yourself, but to save me as a physician. The second thing is this, and Pastor May agree with this. 1 Peter chapter 5, verse 8 tells us the devil is going around as a roaring lion, seeking who he can devour. I'm an ordained minister of the gospel, and I'm telling you, this wasn't by chance. The devil was trying to destroy God's people. And I tell my patients this: we need an army of individuals who are immunized, who can fight the devil and his angels to make sure they don't take care of God's people. So I go two ways. I go because a lot of my patients are religious and they believe in God. And I believe this is important in getting because it was not by chance that this happened. So those two ways help my patient to make the decision to get the vaccination.
Thank you so much. That's very, very helpful. And I'm going to turn to Dr. Oak. As a pharmacist, how can you effectively talk to your neighbors, friends, and family members who are hesitant to get the COVID vaccine? And what efforts are being done at the community level?
Sorry, there's a bit of a delay and I keep cutting you off. Yeah, so twofold. So one, just from the knowledge, if need be, I can break down what's in the vaccine, all of the steps that it took, down to the basic level. If I can explain it to my 87-year-old grandfather, I can explain it to just about anybody there. So that's one thing I do to really make that plain language of science and making it make sense to everyone, so you really understand it. Breaking it down, whatever analogy you need, I can break it down to building a cake, printer ink, anything that would make sense of how simplistic these vaccines really are, and what was utilized to make them, how it's not any new technology. It's really been around for a while. We were just waiting for science really to get funded, and this is what happens when science is funded. But I think what's even more important, being here, living in Alaska, and me particularly, I'm 24 weeks pregnant, so thinking about myself as a vulnerable kind of individual in this state is the social contract. We are very self-reliant here in Alaska. We have to be, and to think that we're at this point where what is called crisis standards of care, where you literally have healthcare professionals sitting in our hospitals deciding who gets a bed. And so it's gone well beyond just if you get this virus. This goes to if your neighbor, if your friend, if your child gets in a car accident, if they're going to be able to get treated, or if our hospitals are going to be so full of individuals fighting COVID that we're running out of beds, that we don't have oxygen tanks. And I'm sure most of you remember that kind of conversation, and it seemed like doomsday back in 2020, and that's what we were trying to avoid. But here in Alaska, we're here. This is where we are at. Like Providence just sent letters about this. This is where we are today here in Alaska. We have the highest case counts that we've ever had in this whole time, and you wouldn't know it if you were walking around. by how our actions are. Idea that Pastor May said about how we think it's done. We think we cured it. We're not there. And you have healthcare professionals that you're hearing, people of color. You've got the Black healthcare professionals who are sitting here begging you to do something about us and to get on the right track. And so whatever you need to hear, I hear a lot of people who are like, I'm just going to take my chances. I'm just going to pray about it, all of that. That's all good and well. But once you get hospitalized, it's a different ballgame. One, if you have hesitations about getting this one vaccine, when you get in that hospital, they are going to throw the kitchen sink at you to keep you alive. Your say in what you take in and the medicines that they're going to pump you up to keep you alive versus this one vaccine, this one dose, maybe 2 doses of vaccine. Like, that's the difference here. So just weighing those kinds of pieces. And then again, from the prayer standpoint, I think back to my training, especially even going back to undergrad. I went to a Christian college, and we prayed over every exam. We prayed over every finals time, and and thinking through that with the prayer warriors who are coming around to make sure that I had the knowledge for a situation just like this. And I hope that as all of us could be conduits of our training and really penetrate and letting people know that this is flowing through us out to our communities for a reason. We are really trying to be instruments here to get this knowledge out and trying to save our people in this situation. And you hear a mixture from us where we're somewhat cynical and impatient. And that's why we're gotten to the point where we're not nice about this anymore, because that's how we feel it. We feel that urgency. And like Dr. Berry said, it's getting cold here. We're moving inside. I think it's supposed to snow on Saturday. There's a 50% chance here. We need to make some considerable changes if we want to get out of this.
Thank you, Dr. O. At this time, I know there's lots of questions in the chat box, and any of you panelists can respond to those questions. I'm going to actually call Mr. Carl Williams. I saw your hand up earlier. If you can go first with your question. Thank you.
Thank you, indeed. I was pleased to see Reverend May there. The largest the most trusted voice in our community has been and is the Black church. And I'm hoping that the Black church will step up and start pushing that voice even louder to the congregants and beyond. And coaches of the athletes will start putting forth that word, because as he said, we talk about the Tuskegee Institute, and a lot of these people have never even heard of that. And that's not the reluctance. It's, again, just apathy on the one hand, not wanting to take the time, and disinformation about, becoming impotent and being traced and being put on a list with the federal government, all that stuff. We got to break through those kinds of taboos more than anything. And I'm hoping, again, the Black church, the Ministerial Alliance will take a louder voice in that regard.
Thank you so much. Before we conclude, I think we can take just one more quick question from the audience. Ali, is there anyone who has a question?
Well, I see some questions in the chat around the vaccine specifically. I don't mind to kind of go through those kind of quickly.
Yeah, if you can take one or 2 minutes to.
Yeah, I can do that. I just see a few just about the vaccines themselves. I did want to reiterate there's questions about the third dose versus booster. And again, I'm going to say this. So a third dose is really, so if you think about Pfizer and Moderna, how those two specifically, you got 2 doses. So you got one either 21 days apart or 28 days apart. So a third dose is getting that. So waiting another 21 days or 28 days and getting that third dose right immediately. So it makes it going from a 2-part series to a 3-part series. And those are for people who are immunocompromised. So that helps you just get that incremental gain just a little bit higher because you're starting off a little bit lower in your immune system. That is different than a booster. A booster comes much, much later when they think that you've gotten as much, you know, kind of coverage as you can, and then it starts to wane, so you boost it back up. So that's what you're hearing with that. It's not a different type of medication. It is the exact same type of vaccine that's coming into you. It is just helping to elevate. So the 3rd doses have been approved for immunocompromised. It's the boosters that are still being sought out, but that's that question. And then I saw a question around pregnancy, and yes, there are benefits. One, of course, for the pregnant mom to protecting her, and this is coming from someone, like I said, who was actively pregnant, got pregnant after being vaccinated, me and my husband. So any fears about the impotency, getting infertile, I am a test case. That did not happen, and have a very healthy baby on the way. But I passed on those antibodies to my baby. With that, I'm protecting myself and making sure that if I did get COVID, which I haven't, but if I did, that I'm going to give myself a fighting chance, give her a fighting chance in that. So there's a lot of benefits from pregnancy, and we're seeing that from a lot of the boards around pediatricians and obstetricians in that space. So I just wanted to get those 2 things out.
Thank you so much, Dr. Old. And as you can tell, there's so much engagement in the chat. This conversation could go on and on, but I just want to thank you all for being here, the panelists. What a great conversation. And thank you also to our participants for joining us this evening. At this point, I'm going to turn to Eric to give us the conclusion.
Thank you, Teresa. What a great conversation. We want to give a thank you to our program participants, and of course, for you who have joined us this evening. We also want to thank our caucus members and Allies for Change group for their continuous support. If you'd like to join our great organization or link to the Allies for Change group within the Alaska Black Caucus, please visit us at the alaskablackcaucus.com. We would also like to thank the Municipality of Anchorage. This program was supported by a grant awarded by the Municipality of Anchorage's Anchorage Health Department. The opinions, findings, and conclusions or recommendations expressed in this publication, program, and exhibition are those of the authors and do not necessarily reflect the views of the Municipality of Anchorage's Anchorage Health Department. Be sure to join us next Sunday as the Alaska Black Caucus joins the Anchorage Assembly for a community dialogue. Until next time, good night, everybody.